terminology. And as I was thinking through this lecture, I was thinking about the derivative of the term psychotherapy and how it was based on some of the mythology of Romans, and which is, of course, based earlier on Greek mythology. As you know, there are many, many Greek gods. Only some of them are listed here with the Roman counterparts. But if you look up the derivation of the term psychotherapy, at least in the Webster's dictionary, you remember that Eros was the son of Aphrodite, and the equivalent of the equivalent of Aphrodite in Roman mythology was Venus. And it's a complicated story, but Venus sent her son Cupid to kill Psyche. And Psyche is not easily translated, I think, in terms of some of our more Western terminology, but it broadly represented the soul of man, which then got further defined as the mind. But that is not a completely satisfactory definition. It really has to do with your sense of being in the world, who you are, which certainly incorporates your mental functioning, but is not the same thing. And as the story goes, Cupid, or Eros, fell in love with Psyche, was not able to kill Psyche, and therefore Psyche was made immortal. Thus Psyche, the mind, broadly speaking, can be greatly disturbed because of Eros, the force that impels lovers to one another, and as one author wrote, that makes wise men speak in the language of fools. That's what love is all about. We lose a sense of touch of reality, and we are compelled due to our nature, our biological nature, to be in connection with one another. But this can disturb our mental functioning considerably. And a fellow named Sigmund Freud thought about this years later. Matter of fact, as you read Greek mythology, you really see how much Freud was influenced. Not only was he interested in collecting antiquities, but the Greek ideas were filled throughout his theories of what he observed with patients. In Freudian systems, and really based, I think, on some of the earlier gods and what they represented, there are a variety of instincts that keep our species going. Instincts that have a certain amount of pleasure or energy associated with them. And he referred to this as the libido, that is the capacity to, the energy component in performing the wishes of basic instincts. I realize this is a rather theoretical and abstract, but in any event, his notion was that civilized man, you and I, need to learn to control these basic life instincts, and he had the concept of sublimating them. That is to express those sexual and aggressive instincts in socially acceptable ways. As he did his work, he also recognized that he could not explain all of human behavior based on the life instincts, that we do things in everyday life that are self-destructive. There are many, many examples of this, from drinking too much alcohol to smoking to using drugs and so forth. And without getting too theoretical, he was impressed that some of our behavior went past the pleasure principle, and we had to understand this complexity. And again, if you go to the mythologies of the Greeks and Romans, they had gods that helped explain why we behave or why we do things that are not always in our best interest. One of the theorists that I've become most interested in is Carl Jung, and Jung wrote a book that separated his relationship with Freud called The Unconscious and the Symbols of Libido, meaning that there wasn't just one source of life energy. There were many symbols that guided how we actually behaved and which controlled our behavior. One of the things that I liked about Jung's concept was that these sources of life energy had to be integrated, not sublimated in life. You've all met people who've been too nice in their earlier life to become aggressive or destructive later in life. You've all met people who have been too mean and never able to form attachments and then later become religious zealots later in life. There's always a struggle to take these forces and integrate them in their everyday life. When I started to work with individuals that had brain injury, I began mainly with the notion of trying to understand how the brain injury itself affected their psychological functioning and whether we could use basic ideas emanating from the neurosciences to help these individuals reconstruct their life and get back to work. And I encountered a number of things that I had not expected to encounter by reading the textbooks. And I'm going to give you a little bit of a walkthrough of what had been preceding the notion of using psychotherapy within the context of brain injury rehabilitation. But I feel impelled a little bit to talk about what exactly is psychotherapy before I get into this. We'll talk about this more in the workshops. Once I was at an NIH conference in Washington, D.C. that had to do with standard of care for rehabilitation of traumatic brain injury individuals. And this very scientifically oriented group asked me to define to the group, what exactly do I mean by psychotherapy? As you know, there are different theories of psychotherapy with different definitions of it. And there are two definitions that have always made sense to me. One that was given to me by one of my teachers, and one that kind of came to me as I started working with patients. The more acceptable, kind of easily understood English translation of psychotherapy is helping the patient learn to behave in their own best self-interest in life. That doesn't mean selfish interest. It means figuring out what's important for you, whatever your culture is. If you're an Israeli, if you're an Italian American, if you're Greek, what are the symbols, what are the experiences you have in everyday life that give you a sense of purpose, a sense of direction, but also help you make decisions which are in your best interest, so that at the end of the day, the end of the month, the end of the year, you feel good about how your life is going, to the degree to which you can. The Greeks and the Romans recognized there were forces other than your own that determined how well you felt by the end of the day, what the gods had decided they were or were not going to do with you. But it is learning to behave in your own best self-interest. This is not an easy task. Sometimes people learn this through growing up. They have enough failures in life, a number of losses in life, and they learn from their mistakes. But it's not uncommon that it's difficult for people to do this by themselves. And having an opportunity to talk to somebody who has some knowledge about your particular medical conditions, if it's brain injury or if you have lung disease or if you have brain cancer, who understands what your health problems are, but also understands you as a person, that you arrived in their clinic with a history and with a cultural background that will influence what you consider to be important in your own life. So it's learning to behave in your own best self-interest. There was another definition given to me that seems to be universally understood by people throughout all cultures. It was given to me by our consulting psychiatrist, a man named Dr. Winnicke. And he said, psychotherapy is like slowly turning the lights on in a room that is dark but is filled with bear traps. If you know what I mean by a bear trap, big iron claws that will crush your foot and keep you there. He said all psychotherapy is turning the lights on slowly in a dark room full of bear traps so you can see where not to step if you don't want to complicate your life any more. It's a powerful analogy, and it's really true. Psychotherapy will not reverse the fact if you were sexually abused as a child. Psychotherapy will not reverse the fact if your father or mother was alcoholic. Psychotherapy will not reverse the fact that if your husband or wife left you. Psychotherapy will not reverse the fact if you lost a child. Those are the realities of your life. Those are what the gods sent in your direction. What psychotherapy will allow you to do is to figure out how to deal with these problems in the most productive way. And many times people have turned towards religion to this purpose, and for some individuals, religion is very helpful. But many people, at least in the Western culture, have become somewhat disenfranchised from religious ways of helping them deal with life's problems because they find that there is no formula, there's no single way in which everybody deals with these problems. And that's where Jung was so powerful. He recognized there were certain components to dealing with these life problems that could be seen throughout various cultures, but there was no simple formula. And that was something that really I gravitated to. Now, if you look at the history of cognitive rehabilitation, Barbara Wilson gave us a very nice overview, and I'm going to give you my version. Some of this overlaps, but it's a somewhat slightly different version of cognitive rehabilitation. And I had an opportunity a while back to write a small chapter on this, and I think there are three really great traditions which are the basis of what we now call neuropsychological rehabilitation or cognitive rehabilitation, that did not include psychotherapy. And I want to go over those traditions and emphasize their strengths, but what they missed, and why psychotherapy has become, in some settings, a crucial component to the rehabilitation of brain-injured patients, no matter if you use the word psychotherapy or not. Anything that deals with the patient's emotional reactions, you're talking essentially about what has traditionally been referred to as a psychotherapeutic issue. This person, many of you may or may not know, but his name was Shepard Ivory France. He was a psychologist and a physician. He worked in the United States in the early 1900s. And he wrote some very interesting papers on recovery after stroke. And he followed patients for many, many years after stroke. He developed the whole concept of what is called constraint-induced physical therapy, motor therapy. Where you hold back, you have the individual not use one arm and then use the other. This was Shepard Ivory France's concept. It's not a new concept. It's been around for a long, long time. And he criticized what at the time was the most powerful theories of von Monaco, saying, you're only studying the effects of the lesion. You're not really looking at how the brain is changing and what recovery is all about. And you can't base good rehabilitation without really understanding what the natural recovery course is. Because much of rehabilitation avoids complications as opposed to facilitating recovery. But in his very insightful work, and he was a psychologist and eventually went out to California and was the first psychologist at the Children's Hospital in Los Angeles. And if you go to the UCLA and you go to the psychology department, it's France Hall. This was named after Shepard Ivory France. But he never talked about the role of psychotherapy at all in this important process of re-educating brain dysfunctional patients, even though he was a psychologist as well as a physician. Now, both Luria and Poppelreuter were extremely insightful individuals that took the more medical approach on which our field is based. They emphasized that what you really needed to do was to systematically assess the nature of the disturbed higher brain function and then develop models that would allow you to, if not compensate, reverse the effects of that dysfunction. Poppelreuter was very interested in visual field defects, and his early work was, could you stimulate at the periphery of the impaired visual field to see if you could expand the visual field. This became something that was picked up in the 70s and the 80s in Germany. While it's still controversial, you can, through behavioral techniques, expand a visual field by a few degrees. Luria was much more interested in the more complicated functions, if you would. Problem-solving language was one that he was extremely interested in, but he also emphasized understanding the nature of the disturbed brain function. He did not talk about the patient's emotional reactions in the context of rehabilitation. He did write, with one of his patients, a very powerful book, talking about a man with a shattered world, and he talked about the person as being a hero. It's interesting terminology because, as we'll get to, it's the hero's journey, which is really the psychotherapeutic journey. But even in that case, he talked about the person's struggles, dealing with adversity, but never got into the phenomenological state of the person. What's it like to have a bullet wound in your left parietal temporal lobe? What's it like to be an engineer that had a bullet wound in your left temporal parietal lobe and you could not do mathematics, you could not read, and at one time you were excellent? What was the phenomenological state of this patient? How was he able to sustain the efforts necessary for rehabilitation? Luria never discussed this at all. Kurt Goldstein, who we hear a lot about, and for good reason, presented the third tradition. He was living, of course, at the time of Poppelreuter. And I laugh when I read this stuff because I'm sure these debates exist now. There are those of us who believe in a holistic approach and others who say just understand the nature of the problem neurologically and that will lead to the best therapy. So the Luria Poppelreuter approach and the holistic approach is still alive and well with opposing points of view. Frida Newcomb, who, as Barbara had mentioned, passed away a few years ago, was a true scholar in the best sense of the word. And she wrote a very interesting paper about what was Goldstein's contributions. And she called him the great precursor of our current activities. And I thought that was a especially nice compliment by Frida because she was from a tradition also that did not emphasize a holistic approach to brain injury rehabilitation. And this is what Frida Newcomb wrote about Goldstein's work. that I think is very true, and it's one of the reasons that many of us have been attracted to this approach. He emphasized the need for long-term follow-up of patients. You really don't know how effective your therapies have been unless you follow the patients 5, 10, 15, 20 years. That's one of the small benefits of getting a little older. You see how these patients actually do with time, and then you really see what made a difference versus what did not. Second, he recognized the great individuality of patients and the variability of their performance over time. This is really an important issue. One day patients would do a lot better than on another day, just like the rest of us. Sometimes the talk goes a little bit better, a little bit more articulate than in other times, and I'm sure there are many variables that contribute to that. Brain injury is no different, and Goldstein, as a physician, even was measuring changes of heart rate and blood pressure, showing how variable they were after a brain injury. There was not a simple pattern of getting better or of getting worse. There was great variability in this process. But he saw the individuality of patients and the need to understand the variability of their performance. As Barbara also mentioned, he was the first neurologist that really had psychologists help him out. And he believed in psychometric assessment, measuring quantitatively how the patient did, but he also recognized the limitations of it. And we certainly see that today. I think any of us who work in brain injury rehabilitation know that the numbers tell us something, but they don't tell us 50% of the importance of the variability. Goldstein was aware of this. Another point that he emphasized that we all see is the problem of fatigue and how to work with that. What exactly causes the fatigue we see after brain injury? In our early work with brain dysfunctional patients, many of them were described as irritable. They would work with us in cognitive rehabilitation activities throughout the course of the whole day. They were exhausted by it. They went home, had a good night's sleep, and the next day they were less irritable. And many family members told us, it's an interesting thing, as the patients go through these day treatment programs, they're less irritable. Well, it may be because we've structured life for them better, because we've taught them how the brain injury has affected them, but maybe we did something to their mental energy. I know that if I'm working on a problem consistently, I seem to have more energy in approaching that problem the next day. And dealing with this fatigue component is really very important in all forms of rehabilitation. Goldstein then talked about the importance of careful observations of the patient's responses to their failures and their natural preferences for using one form of compensation or substitution versus another. He watched what the patients did and then figured, could I add anything to it? It's interesting, if you read Luria's book, The Restoration of Higher Cortical Functions in Man, Luria said, I have nothing to say about substitution training. It's very interesting to me as I read that. He says, I don't know how necessarily to figure out better ways to have the patients substitute for what they do. He was more, again, interested in the restoration of function, getting areas that could function normally only if you knew how to approach them from a different behavioral perspective. And then finally, Goldstein, and I think this is really extremely important, it's the hallmark of what Dr. Ben-Yishai developed and others, having the rehabilitation relate to real-world activities. Could you get them to talk to other patients in a reasonable sense? Could you help them learn to be reliable? Can you get them at work on time? Can you help them choose a level of work that's truly matching up with what their skills are? This was all of Goldstein's tradition. But it is interesting to me, and I've read and reread Goldstein's work several times over the years, he never discussed the role of psychotherapy in brain injury rehabilitation. And I'm often puzzled by that. Why did he not? Because he was so insightful in so many other areas. Was it because of the strong psychoanalytic influence of the time and a belief that dealing with early life experiences would be a sidetracking activity that would not really help the patient with the real-world problems now? I don't know. Maybe Yehuda can give us his view. But Goldstein was extremely insightful. He trained, actually, with many psychoanalytic theorists and also with some of the Jungian people. Goldstein was, as you read his life's history, Wernicke was one of his teachers. He certainly studied with people who worked closely with Freud, and I know he studied with some Jungian scholars, but he never talked about psychotherapy. But yet, in our own work, we observed things that made us compelled to think about the importance of psychotherapy in this form of rehabilitation. And one of our early cognitive group activities, which I'll show you in our workshop this afternoon, we had a young man named Ricky. And Ricky was the fellow who was quite tangential in one of the cognitive retraining tasks. We'd ask him about why he was in the program. He began talking to us about his automobile accident, and then he'd talk about the accident occurred in in Norman, Oklahoma, and then he told us about the car that he was driving, and then he talked about how much he missed the car, and then he talked about how his aunt had a similar car. He went on and on and on and never got to the point. And when we stopped Ricky with his tangential thought process, he would look at us and say, I know, but I'm getting to the point. But by that time, we were lost. So it seemed like Ricky was not a very astute thinker, a very capable person. But in fact, he was extremely perceptive. He just didn't have the words to explain what he was going through. And one day, spontaneously, I go back to the importance of the spontaneous drawings, he presented us this picture in our milieu. And he said, you know, the other day when I was trying to talk to you guys and tell you what it was like and why I was in this rehab program, I don't know why I couldn't do it, but you've been teaching me about brain anatomy, and I took this book home, and I decided to draw what I experience. And here you see a lateral view of the brain. You see a cord coming from it, partially plugged into a wall socket with sparks coming out. And he says, you know, since my brain injury, I don't have the clarity of thinking that I used to. It's like I've lost the energy in my thought process. Some days when I travel and have jet lag, I know the feeling, but luckily it goes away with a few hours. But he said, I don't have the capacity to think clearly and sharply. Also, he took the skull and turned it over, and he shows these bubbles, and he says, I have a sense of pressure in my head. It's interesting to me, a number of patients with more mild injuries will talk about this sense of pressure in their head. We don't understand it. I've never had a physician explain to me exactly what this pressure means, but it is a phenomenological state of many of these individuals. So Ricky told us through his drawings what it was really like for his brain injury, and this led to a discussion in group psychotherapy. What are your feelings? What are your feelings about yourself and your life after your brain injury? And again, Ricky presented us this spontaneous drawing a few weeks later. You have the human skull, which is always a sign of our mortality. Throughout all cultures, the human skull reminds us we will die. This is not a pleasant thought. Many of us spend time thinking about things that take our attention away from this reality. He has the brain coming out of the skull. And then you can see, I don't know if I have the pointer here, but you can see these humanoid features that have holes in their head, but they're cephalic in nature. He's got one over here, which expresses what many patients do experience at some level. It's not just an expression of sadness or horror. It looks to me more like agony of what it's like to live day in and day out with a brain injury. I've had the opportunity to examine physicians that have had brain injury, attorneys that have had brain injury, extremely wealthy businessmen that have had brain injury. I have experiences in working with cowboys that have had brain injury, oil field workers that have brain injury, janitors that have brain injury, and it's all the same. It doesn't matter how successful you were in life, the effects of the brain injury are devastating. And how do you talk to somebody about that? What kind of words do you use? Many of them do not have the adequate terminology or phraseology, but their drawings or the art forms tell us what they experience. Where do you deal with this aspect in brain injury rehabilitation? Where is it dealt with? And this has been my argument for many years. You must have a psychotherapeutic component, if you use the word psychotherapeutic or not. Some prefer psychosocial, some prefer cognitive behavioral, some prefer other terminology. But for me, the closest to the term is psychotherapy, because you're dealing with the human psyche, you're dealing with man's soul, you're dealing with their ability to deal with the problems that they face in their life using the symbols that are important in their culture. They help guide them. So in the context of that, again, we modified an approach that was truly pioneered and developed by Dr. Ben-Yishai to include psychotherapy. We believe that cognitive rehabilitation and various forms of remediation were crucial. But quite early, I became convinced we were going to have a very difficult time truly restoring higher cerebral functions. It's possible. I shouldn't say it's possible. It's going to be interesting to see if you can do this in children as the brain develops. With adults, once the brain has matured, I think it's very difficult to demonstrate true restoration of higher cortical functions that nature itself would have not done. But compensation has clearly been extremely effective for many patients. And it becomes a hallmark of any form of neuropsychological rehabilitation. The establishment of a therapeutic milieu, which is a protected environment that allows people to have group experiences which are therapeutic for them. That's what it means, of course. But in addition to that, we felt there was a specific role for psychotherapy that would be done both in group format as well as individually. It was also interesting to me, when I first started at the Barrow Neurological Institute, about 3 or 4 years after a book was published in 1986, I had a whole series of Japanese visitors come to see our program. As you know, when the Japanese come, they don't come with one, they come with 10. And they bring their father's best friend, they bring their professor, they bring the people who are studying under them. And I was surprised that these Japanese neurologists, and they were neurologists, they were not psychiatrists, were coming to the center to see what we were doing. And after a long period of time, we could finally kind of ask them a question and get an answer that was not politically correct, but was really how they were feeling. I said, why are you here? What is it that you wanted to see? And they said that they wanted to see group psychotherapy. They could not imagine talking about their feelings in a group. It would seem too overwhelming, too against their rules. But it's the human condition. It goes back to all of us have a desire, not only to talk one-on-one about what we experience, but we do have a desire to talk in groups. We want others to know what's going on. And one of the reasons holistic programs are so successful is the small group activity, the bonding, the discussion of all of the feelings they have regarding to their brain injury. They're not alone. I might make a side point. In doing psychotherapy now for a number of years with people without brain injury as well as with brain injury, I've been told this by many brain injured patients and their family members. You don't have to solve all of the problems in my life. I don't expect that of you as a psychotherapist, but I don't want to be alone with the problem. I want another human being to know what I'm suffering with. And that in itself gives me a sense of strength to deal with the problems the next day. So the importance of this psychotherapeutic component becomes vital. We also modified our program to include protected work trials throughout the course of a given rehabilitation day. And all programs, I'm impressed, has the personality of the clinical director. And so programs will vary in how they do this. But because many of the patients discounted how the memory problems actually impact their everyday life or their attentional problems or their socially inappropriate behaviors, we saw what they did on work trials and we brought that back into the cognitive group and to the psychotherapeutic groups. So it became not only an opportunity to see what could the patient actually do in the real world, but have real world experiences of the patient that could then be discussed in these therapeutic activities. That's why it became very important for us. In the context of this, we learned this lesson over and over again. If you did not engage the families in the rehabilitation process, you were in trouble. Because the families, A, knew the patients better than you did. They lived with the patient for many more years before you did. And second, they're going to live with the patient a lot longer than you will live with the patient. So if you didn't get the families to agree, see your perspective. They did not always have to agree on your perspective, but see your perspective of how you're working with this individual and form a therapeutic bond with the families. Not having psychotherapy with the families, but a working relationship. If you didn't have that, you were in big trouble because you could do great things while the patient was in your hands and then they leave and go back to the family and it goes downhill. This is not adequately assessed in follow-up research, by the way. In everything from vocational rehab to long-term outcome, you should be assessing what was the relationship of the rehabilitation team to the family in order to really determine the outcome of your work and what are the variables that predict outcome. Finally, in our own experience, the team had quite a set of emotional reactions to this work, and it had to be managed and had to be worked with. And this is often not discussed in many settings. One of the real powers of Dr. Benirche's program was daily staff meetings, staying on top of what's going on. Not a staff meeting once a week, not a staff meeting once a month, daily. And you say, how expensive is that? Well, it's expensive not to have that. You will not make progress with your patients unless your team is working closely each day as to what is going on. So against that background, we felt psychotherapy was extremely important. The practical question often comes up, how does the process of psychotherapy or psychotherapeutic interventions actually begin? How do you start this? I mean, the person said, I have a brain injury, and I want to get better with my language, better in my memory. I didn't come here for psychotherapy. My gosh, don't get into my mind. I want to do better in terms of work and school and so forth. There are many, many avenues by which psychotherapy begins. And remember the definition: learning to behave in your own best self-interest, turning the lights up in a dark room full of bear traps. The very first patient that I worked with was a young man who had a severe traumatic brain injury, and he was aphasic. And I wasn't so much thinking about psychotherapy when I started with him. I was thinking about getting him back to work. He wanted to be a librarian prior to his injury, and he was aphasic now. What a rub. How do you get an aphasic person to work with words in a library? And I remember at the University of Oklahoma, I would take him to the medical library, and we would learn to sort books and see what kind of helper he could be. And in the course of just interacting with him daily, he spontaneously told me a dream. He dreamt the night before that he was crying, but he was crying only out of the left eye. When I asked him about this, he said to me, people told me that I have aphasia. I can't speak because I have a left-sided brain injury. And in his image, his sadness over the aphasia came out through the symbol of crying out of the left eye. Okay? The power of these symbols to tell us really what's going on. It struck me at that time, and we now began to talk about his sadness. This led to a discussion of why he was now involved in the martial arts. After his brain injury, he wanted to know karate. And the first level was to think about self-protection. Patients feel vulnerable, and so many of them want to be able to physically defend themselves. But as the discussion went even deeper, he talked about how angry he was that he had suffered this brain injury. He was a victim in an automobile accident. And if anybody ever got in his face again, he'd show him a lesson or two. He would beat him up physically. The anger, but the sadness underneath that anger became a powerful source. We began talking about his life, what he planned on doing, and eventually he was a helper in a library. He filed books. Not a great accomplishment, but it was something. He loved being in libraries, and I know what the feeling is. I love being in libraries. But he had a place that he could be, and his psychotherapy emanated from his spontaneously telling us what his feelings were associated with his brain injury. At another level, early in our work, we had a physician who was training to be a radiologist. She was a tall, thin girl, not especially attractive by Western standards, but a highly intelligent girl. And she wanted very badly to be a radiologist. And she suffered an aneurysm in the right parietal lobe, and it was surgically clipped, and there was no obvious neurological signs. Okay? But as you can imagine, she had visual spatial deficits because of her right parietal disturbance. Nobody ever picked this up. She went back, she was released by physicians to go back to her residency program, and within the context of that, she suddenly started to recognize, I shouldn't say she started, her supervisors were recognizing that she was not very astute in reading at that time, the CTs and the skull x-rays. She was not. She was missing things that she shouldn't be missing. She got overwhelmed by this and dropped out of her residency program, did not use the initials MD after her name, which in our culture, that's a tremendous accomplishment to become a physician, and to have those MD initials after your name is something that is taken with a great deal of pride. But she would no longer do that. She chose to be a statistician and was actually sent to me by a neurologist because of depression. And in the course of working with her, you can imagine here is this very intelligent woman whose whole identity ball and you miss hitting the ball on the tee, and you swing again and you miss it, and you say the damn tee is wrong or the ball is wrong. You don't recognize, I can't swing the way I used to. This is common after brain injury. And then I said, when it dawns on you that you don't have the skill to hit the ball the way you used to, what do? Do you give up the game of golf and you say, I'm going to start playing tennis? Or do you continue to play? And let's say you make it the story interesting. Let's say you were a very good golfer and you played at a high level. What if you now have to play at a much lower level? Do you love golf enough that you're going to continue to play the game even at a lower level, or you're going to stop playing golf? Many people face this, particularly in professions. She came to the conclusion she will remain as a doctor, but she could not be a radiologist. She took a job with an insurance company, and she would do general histories and physicals. But she was able to reconstruct her life in the face of, not despite, her brain injury. She was fully aware that she had lost a lot, but in the context of many personal discussions, with many descriptions of images that came out in dreams, she was able to reconstruct her life. These experiences early in my career convinced me that without a sensible approach to psychotherapy, you would not help a half of the people that you see. It also became important for us to recognize that the psychotherapeutic activities needed to be embedded within the context of other rehabilitation activities. One of the powers of the holistic approach is you see the patient several hours on a given day. You see them in a cognitive retraining group. You see them in individual OT and PT. You see them in work trials and so forth. And a lot of emotions come up in the course of that day that now become very useful to work within the course of the program. The old model of seeing the psychiatrist once or twice or 3 times a week in the office wasn't adequate because you're not getting a sample of what is the person really doing in everyday life. And I think this is one of the reasons people thought psychotherapy might be a waste of time. If I really don't know what's happening in a person's life and I only see them in my office for an hour at a time, then I can't work with them as well. But if I see firsthand how the behavior emerges in a group activity, then I can use that very effectively in psychotherapy, and I'll give you an example of this. In Phoenix, several years ago, there was a young woman who was injured by a drive-by shooting in Arizona. We are close to Mexico. There are a lot of drugs that come up through Mexico, a lot of gangs in the southern part of Phoenix, and it can be quite a dangerous place. And this was an Hispanic young woman who was just finished graduating from high school and was really minding her own business, and a drive-by shooting with a shotgun shot her. And this is the skull x-ray. Many of these pellets did not enter the cranium. They stopped at the level of the skull, enter the brain, I should say. They stopped at the level of the cranium, but many did. She had a subtle aphasic disturbance as a result of the problem. But when I first saw her, she was on our inpatient neurorehabilitation unit. She was sitting in a wheelchair, and her head was down. Many of these patients will not look at you face to face. Her head was down. She had the typical surgical haircut of half of her head completely shaven, and she had beautiful, beautiful dark black hair. And this was obviously shocking to see a young girl like this with beautiful hair, but one side completely bald. She was obviously humiliated by this, and she didn't want to look at anybody. She would look down. And so she put a bandana around her hair to cover this up. And when I spoke with her again, she was cooperative, but would not volunteer very much, would not make eye contact, as I mentioned. But we talked with her and her family, and she agreed she would enter our day treatment program. So she began in our program, and she was the ideal patient. She did everything we asked her to do. She was cooperative, never irritable. If anything, she was more quiet than we would like them to be. And she went through maybe 2 or 3 months of absolutely easygoing, cooperative types of interactions. And one day, in our cognitive group, they were videotaping patients for various exercises. Videotaping is a very powerful method. And when they got to one exercise, imagine you're interviewing for a job, and we're going to catch what you say on the tape and then feed back to you. When they got to this very cooperative, this very congenial young woman said, "Absolutely not. You're not videotaping me." And the speech pathologist and the psychologist in the group at the time said, wait a second, you don't understand. This is a part of our therapeutic milieu. I mean, part of our holistic approach. You must do this. Absolutely not. I'm not doing this. The rest of the patients are listening. There's a rebel here in the group. I'm not doing what you're asking me to do. So you can imagine they come to me as the clinical director and say, George, do something. Convince her that she has to be videotaped. And I said, well, let me talk with her before we decide about convincing her. And so I began to talk with her, and she was very quiet. She said very little to me. And again, her head was down, and she was just kind of doodling on a piece of paper, making little scratches. And I asked her, tell me, what's the problem? Wouldn't say hardly anything. Did somebody offend you? They wouldn't say anything. Are you embarrassed about videotaping? Wouldn't say anything, just doodle. And she said, I'm not going to do this. And we had about 3 sessions, and then finally, and I don't know why I did this, and I really don't think I've done it very many times since that time, but I said to her, the last discussion I had was on a Friday, and I said to her, if I give you a piece of paper with different colored pencils, will you go home and draw anger for me? If you ask me why I did that, I can't tell you. And she looked at me and said, okay. So she went home, and on Monday morning, she gave me a picture. Before I show you the picture, I want to tell you of a quote of probably one of the best therapists that ever lived, named Dora Kolff. She was a Jungian analyst, wrote a book called Sand Play. She was in Zurich, and she had this big box of sand with all of these toy figures. We're going to do this with children when we begin our program. And she would have these very astute businessmen from Zurich. You can imagine the bankers from Zurich coming into her room, and she had this big sandbox with all of these toy figurines, and she'd say, play with them. You say, you psychiatrists and psychologists are nuts. What do you mean play with them? But she, in her book, describes how whatever stories they pick, whatever figurines they pick, and how they play with them and stand in the sand helps them. And she makes this important point. With the help of the exterior picture, the inner problem is made visible and brings about the next step of development. There's a very insightful comment. It is not curative like that. It helps you see what's the next step in that person's psychological development. And this is the drawing this woman gave me, who would not say very much. First of all, you see the dark box, and she was doodling on the paper, very similar boxes. You see the furrowed eyebrows. She's angry. You don't see the eyes. You see, perhaps if you look closely, the tears coming from the eyes. You see the head partially shaven. And this lady, who would have very little to say, actually has a lot to say. She says, I'm sad. I'm by myself. Why me? I'm trapped. I'm alone. I'm scared. Confused comes up over and over and over when we interact with brain injury patients. Confused. What does confused mean? Confused means that a system that you use to solve a problem no longer works. My best example of this was a German businessman that happened to have suffered a stroke while in Phoenix. And he was very good at mathematics, and we asked him to do the problem, what does 42 minus 28 equal? And he looked at me, and again, in the past, he would give the answer like this. He looked at me and he says, 42 minus 28, let's see, well, I round up the 28 to 30, I subtract that from 42, it's 14, I then subtract the 2 from the 28, the answer is 12, oh, I don't know. And he throws his hands up. That's confusion. You use a method you used to use to solve a problem, it no longer works for you, and you don't know how to reapproach the problem. That's confusion. That's what brain injury does. You don't know how to reapproach the problem, and this is what she experienced. She goes on. She says here, I'm trying to get out, but I'm banging my head against the wall. I can't quite read that one, but she makes a statement. Okay. Yeah,
I'm not in the mainstream.
Right. Yeah, I'm not in the mainstream. She missed being in school with her college schoolmates, but this is an important one. I can't be the perfect patient. I cannot be the perfect patient. This was her existential issue. She was a good girl for too long. She now had life give her a problem that God, religion, the history, their culture would not allow her to solve that problem. I cannot be perfect. Like people told me, if I did the right thing, everything would be okay. But it didn't work out that way. I see this issue come up over and over in life. I thought I was doing the right thing. I thought I was a good person. I followed all the rules of society. And then life throws me a curveball. The Greeks would have said, Zeus sent me a lightning bolt, or Poseidon decided to put the boat in the water. This unexpected event occurs which changes my life, and now I have to deal with it without the rules that I followed to help me no longer help me. Now we're talking about psychotherapy. Now we're talking about the dialogue between you and another human being who hopefully knows something about your brain injury, hopefully knows a lot about human nature, and has been along this path before. When we train psychotherapists, one of the analogies I use is, imagine you are a guide in a jungle, and you know a little bit about jungles. You know when the birds get quiet, something's going on. When the birds get loud, something's going on. You know if you get off the path too far, you can be in trouble. But you've never been on this path before. You only know something about paths in the jungle. That's what a good psychotherapist is, because they don't know what jungle they're going to walk in with a given patient, but they know something about how to survive in the jungle. This woman provides a very interesting story. Again, I do not have the time to tell you all of it. Maybe in the workshop we'll get into this, but it's a very powerful story, and it follows the theme of the hero's journey. For those of you who have ever seen Campbell's book, The Hero with 1,000 Faces, this is a theme that we see over and over come up in the psychotherapeutic process. Something happens to you, and you don't want to deal with it. You don't want to deal with it. You find 10,000 reasons not to deal with it. Then you face it. Then you go and you leave the security of home. Most heroes have to leave home to be a hero. Not all, but they have to leave their house. And when they go out, they face something that scares the hell out of them, not something that bothers them a little bit. When they face what is frightening them, not only with bravery, but with cunning, a good hero uses the intellect as well as having a steadfastness to dealing with what frightens them. When they face that, they come home by another pathway. They come home by another way. Life doesn't turn out exactly the way they thought, but there's a rebirth, so to speak. They've grown up a notch. And this is the process that occurs over and over in the psychotherapeutic experience. And again, during the workshop, we can do this. Now, sometimes people will say to me, does everybody need psychotherapy after a brain injury? And of course, the answer is no. Not everybody needs psychotherapy, but they need to have certain basic human skills, and they need to be lucky enough to have certain people in their life to deal with the effects of brain injury. And I'll give you 3 brief examples. I told you about a young man who had aphasia when I first saw him. There was another young man I saw who had aphasia who fell from a mountain. And we talked about him yesterday, who we played back his aphasic speech, and he was surprised when he recovered from his aphasia, that he was aphasic at any time. He had just been married, and his wife was a physical therapist, in finishing her physical therapist training, and he was getting a master's degree in business. And he was headed for a very high-level business career, but he could not ever do it again. But he truly loved his wife, and she truly loved him. And he said to her, I realize I cannot be the guy I wanted to be for you. I cannot give you the Mercedes-Benz. I cannot give you the big house, but I can give you me. And she was from Minnesota. She was a Swedish background, beautiful woman, and she wanted to go back to Minnesota. And he said, I will do anything to help support the family if you want to go back to Minnesota. And he says, I'll even be a mailman. And she smiled and she said, okay, honey, let's do that. So they went back to Minnesota, This high-level guy who was going to be a high-level businessman became a mailman. I would say like every 3 or 4 Christmases, I get a card from them after 20 years. Okay? Their family has grown. They now have grandchildren. The mailman from Minnesota never needed 1 day of psychotherapy. He had his head screwed on right before all of this was injured. He was lucky enough to have a wife that could accept him given his cognitive deficits. He had the knowledge to know that he had to give something to the relationship for it to be maintained. Didn't need 1 day of psychotherapy. The accountant who had a large right hemisphere stroke, who could no longer be an accountant. He also lost his sexual abilities. He was an older gentleman, but with his parietal lesion, he had a sensory motor loss, and he could not get an erection. And it was very difficult for him to perform sexually. And he and his wife really enjoyed a great sexual life prior to his stroke. And he said, what am I going to do? He said, I have all of the money that I need to take care of her and I. I have an arm that doesn't work and a leg that doesn't work. I have a penis that doesn't work. I don't feel like a man. I just feel terrible, and even though my wife will accept me and she'll always say nice things to me, she'll never really tell me that she's disappointed in me, in my heart, I'm not living up to be what I should be as a husband. And he became depressed. And we just talked a little bit about what could he do, and he said, well, he always had a great sense of humor, and he'd always make his wife laugh. That was one thing that kept the relationship going. So we stumbled on it together. I said, look, why don't you go out? He had a driver. He wasn't able to drive the car. I said, why don't you go out and you buy 356 cards, love notes. And every day you write something funny, something sexual, something entertaining on these cards. And when your wife gets up in the morning to take her shower, you put the card under her pillow. He loved the idea. He did it the first time. His wife smiled and laughed, came over and gave him a kiss, did it a second time, and she was amazed that he persisted to do this yearly, and he did it for several years before he died. Every day he gave her a card because he had an insight, a knowledge that he needed to give something in order to get something back. So the love relationship helped him sustain the consequences of his stroke. The final example of a man who did not need psychotherapy was the electrician who was electrified by his wife. It's an interesting story. This electrician, I remember very, very well. He fell from a ladder, had bilateral frontal lesions, was extremely hyperverbal and tangential. He had no insight, none whatsoever, about his inability to function as an electrician. He came to the rehabilitation program because his wife said, you needed to do this. He trusted his wife to the nth degree, so he did it. And in the course of the rehab, he would say, I really don't need to be here. I don't know why I'm here. I know I can be an electrician again. I know I can do what I did before. And over a 6-month period of time, his wife said, honey, I want you to keep going to the rehab every day. The psychologists there, they understand your brain injury, and they're going to try to help you. Then he got to the point where he accepted he could not go back to work, but the issue was voluntary work. What would he accept as voluntary work? And again, he struggled with, I don't want to just carry things from one. He was going to be like a delivery person within a hospital. He was a skilled electrician. He didn't want to keep just carrying boxes from one place to the next. His wife said, this would make me happy if you did this. This would make me feel good. And he said, for you, I will do it. And he did it. Never needed 1 day of psychotherapy. He remained fairly adjusted in the relationship. But he had a relationship, and he had a premorbid way of viewing the world and relationships that were present that allowed him to deal with these difficulties. So not everybody needs psychotherapy, but many do. Now, I realize the time has gone past what I was going. I should stop by 9:30. I will just end with a couple of brief scenarios. Psychotherapy of spouses of brain injury is something that is often not discussed adequately, and yet there's a need for it. It is not uncommon that a spouse will say, do all you can for my husband or my wife, I'm fine. I can handle it. But in the course of working with patients over the years, we find that this is not always true of all spouses. And one example is one that we've written about. There was a woman who had married a man. It was a second marriage for them. She was in her 30s. And she had been in very abusive relationships before this second marriage. So she really was very happy to be in the second marriage, and she recognized that her husband, who was not the wealthiest or not the best-looking man, was a man that was really good to her. And so she decided, after he had his anoxic encephalopathy, she was going to take him home. And the therapists in the rehab unit were very concerned about this because he did not have control of his bowels or his bladder. He had to be diapered. He would yell and scream at times and be quite a handful. But she said, "No, I'm taking him home. He is my husband and I will care for him." The neurologist on the unit at that time asked me to see her. And when I spoke with her, the first words out of her mouth were, literally the first words were, "Don't you dare attempt to change my mind. This is my husband and I will take care of him." She did take him home, and in the course of the first few weeks, we began talking about what it was like and what she was experiencing. And then at one point, maybe 3 months really into the dialogue, I asked her, in a basic way, what are your needs? What is it that you need, and how are your needs being met in life? This resulted in immediate and intense crying that did not stop for several minutes. She could not tell me exactly what her needs were, but I had touched a nerve. We had then begun to talk about many, many issues in her life, and we stopped talking about her husband. It's quite interesting. We started to talk about her husband, but now we talked about her, and she brought this up. I didn't ask for this. She brought up the abusive relationships she had. She brought up a variety of very powerful early childhood experiences. She tried to figure out how did she get from her early life to where she was then. And in the context of this, she started to have dreams. Again, I don't ask for dreams. The patients tell me I had a dream. And in the context of those dreams, she dreamt that there was a wolf outside of her door one night, and it was very frightening to her. And I asked her then to draw the dream, which is something the Jungian analysts do all of the time. She drew a picture of a wolf with glaring eyes, and she says the picture doesn't capture how frightened I was of this particular dream. And then she talked about the wolf turning its arm over, and there were big sores on the inner side of the wolf's arm. And then she started to make connections with how trapped she felt in life. On the one hand, I love my husband. I want to take care of him. On the other hand, I'm repulsed every time I have to clean his dirty diapers. I'm repulsed by his yelling and screaming. I don't know what to do. I want to show him that I love and care for him. I cannot live in this life circumstances. These are the complexity and the ambivalence that come up in all intense relationships. This was right out of Sigmund Freud. It's not out of cognitive behavioral therapy. It's not out of systematic desensitization. It is out of what Sigmund Freud and others saw and recognized. And that's why I believe one must have a much more sensitive ideas of what human beings go through than a strict behavioral approach. She then began to talk about a variety of other feelings, and then she said to me, "Why have you not asked me about my drinking?" She was furious with me. And one of my best teachers told me, when patients want you to know about something, they will tell you. Don't ask too much too soon. They will tell you. And at that point, we then began to talk about her alcohol abuse, which she never talked about earlier, that existed prior to her marriage. She would come to the rehab settings totally intoxicated. The nurses and the physicians and physical therapists never picked it up. And then she began to deal with her alcoholism in relationship to a husband that had brain injury, and she made great progress. So I will simply end with a couple of brief comments. Traditionally, psychotherapy was aimed at helping people reduce their anxiety, depression, reduce interpersonal conflict in non-brain dysfunctional individuals. Pollack, the psychiatrist, wrote insightfully about psychotherapy with brain-injured patients, and he talked about the ability of people to obtain what he called an acceptable sense of self. Yehuda, you have similar concepts about psychotherapy. But in all, in my mind, it's dealing with the problem of lost normality, and I tried to write about this in the past. You are no longer the same person you were before. You've lost it. How are you going to deal with that problem of lost normality? Your culture, your religion, your philosophical ideas, your relationships with people and your understanding of your own makeup, your own psychodynamics, ultimately help you deal with the problem of lost normality. When you deal with that problem, you are not in a false sense of euphoria, you are a sense of being able to enjoy life in the face of the suffering that you have. You now become an adult. And as Dr. Ben Yishai said in Deggendorf, Germany many years ago, you can't be a sourpuss and be rehabilitated. And what he meant by that was you can't have a sour attitude about yourself and life and go ahead and move forward in life. So here I will stop my comments about psychotherapy on a Sunday morning. I hope the discussion again is of some help to you clinically, and we can discuss these things in more detail in the workshop. Thank you for your attention, and thank you for coming in on a Sunday morning.
Thank you very much indeed for your excellent lecture, not only documented from the scientific point of view, but also a very nice and human lecture that we all enjoyed. I don't know if you have any questions from the audience. If there are any questions from the audience, we may take one or two questions. And I would like to ask Dr. Katami if we are entitled to have a short break in between, or we continue with the next speaker. No break?
Yes.
Are there any questions from the audience for the first speaker, please? May I ask a question myself then? How about children? We had a short discussion before your talk. What is the youngest age of a child having suffered the TBI to receive psychotherapy in his treatment?
You know, we're just beginning. Yes, we're just beginning our day treatment program for children, and so I don't have a lot of experience with children with traumatic brain injury. In my training, we did psychotherapy with children with psychiatric problems of various types. But I can give you one example of a young man that we treated in Phoenix who was 21 when he came to us, but was 9 years old when he had his traumatic brain injury. And in the context of this group, what we often see is when the brain injury occurs early in life, not only does it affect your cognitive capacities, but as it affects your cognitive capacities, your interest patterns reduce. And so he had very few things he was interested in. And this was a real problem for establishing friendships. The other basic problem that he had was the ability to empathize with what other people's situation was. It was interesting to me. It was like developmentally, he had not gotten to the point of being aware of others' needs as opposed to just his own needs. And for him, it was still the problem of lost normality, but it was complicated in the sense that he had not pictures with them. But try not to ask too many questions because it's hard for them to communicate. But to just spend time with them, to build that relationship. Then I take the lead. However they attempt to communicate, I wish to communicate. I have found that drawings, pictures, but art forms, sometimes their favorite music. We might talk about what music we like. Let them pick the modality in which they try to express their inner experiences, and then that leads to it. So it's one where I first try not to talk, and then see what comes natural as to how they wish to communicate. But art forms are very helpful in that regard. Okay, I'll stop here.
Thank you very much indeed.
We continue with Professor Malek.